Welcome everyone. I'm here with Dr. Kesh. We're gonna talk a little bit about the OPTIMUM trial, a very game-changing trial. So please, Anis, introduce yourself and tell us a little bit more about your role in the trial.
Yeah, Ricardo, thank you for having me. I'm very proud to be talking about the topic. I think it's exciting, really an exciting trial. So I was involved in the planning of the trial with a committee, which was a run-up in, I think, 2020, in the middle of the pandemic. And then we finally got the trial going. I think it did take a little longer because of COVID and post-COVID problems with MRI capacity and so on. But once it started accrual, I think it went rather well. And so we're really happy as a group that we got this thing through. And yeah, let's dive into the topic.
Okay, very good. So tell me something. What was actually the difference with the other trials and the main input for developing this research?
So, I mean, micro-ultrasound is a new diagnostic tool. It's been around since 2018, so it's not so new. And all the data that we had so far was adding micro-ultrasound to the MRI pathway because the ones who adopted the technology, we started using it in our already set up pathway, which was MRI driven. So there were some groups in Milan, our group in Berlin, and some other groups who were publishing on it. And we saw that we had quite a benefit in some of the cases where we added about 10 to 15% of significant cancer that we found only on micro-ultrasound. So the technology really was very promising. So when the trial was being set up, there was a long discussion about how to go about it and how the different arms should be set up. So in the end, after a long discussion, was this 3-to-2 ratio, where 1/3 of the cohort would get only micro-ultrasound. The other group would get micro-ultrasound in addition with MRI. And then, of course, you would have the standard control arm, which was MRI, was the second half. That was one thing I think that was quite well done because it showed that we could also just use micro-ultrasound as alone or in the combination. If that would have failed, we would have seen the differences. That was the main goal. I mean, it was a non-inferiority trial. So the goal was not to be better than the MRI or the same, it was to get close. And that's what we thought we would be able to achieve. The second thing that was really important was that all the men were getting biopsied. I think that's when the trial was presented at the EAU. I think this kind of got lost, that everyone had received the biopsy. Also negative imaging groups, so PIRES 1 and 2 and PRIMUS 1 and 2.
Okay, and what are the main findings? So can you summarize a little bit for the ones who are hearing our podcast? What are the main findings in the three groups in terms of cancer, significant cancer? What did you find actually?
So the main finding, as it was in non-inferiority trial, actually the trial was stopped after an interim analysis. And I think that's an important point because it was a pre-planned interim analysis. And the threshold normally for the trial is -10%. You can be up to 10% less than the control, which was the MRI. In this case, it was 1%. So below 1%, the trial could be stopped. So external review from a quite prominent statistician in New York, who was consulted how to proceed. Actually, the trial was then said, okay, this is preset. You can stop the trial because the final goal was achieved. And that's quite rare that, that a trial gets stopped early for doing so well and for getting the main spot done. And I think it was quite difficult. I think we wanted to pull through as people who were on the trial, but I think it's probably good that we stopped it because the results were just so convincing. So in the end, micro-ultrasound was not inferior to the MRI. Actually, overall, micro-ultrasound detected 46% of significant cancer defined as Gleason grade group 2, compared to 43% in the MRI arm. So actually, the differences were 3% pro micro-ultrasound. Of course, it's not set up to be better than the MRI. So it was clearly level up with the MRI. And I think that's the key finding. And it's probably even better than we had expected as the investigators of the trial, I have to admit. That's my personal opinion.
And tell us something more, because I think that not everyone is actually knows what micro ultrasound is. So, if you could just introduce how you perform a micro ultrasound, how difficult it is, how
Yeah.
also how long does it take? I mean, I have tried it, but I'm not an expert, so I don't know how much does it really gets to analyze a whole prostate, because we are used to do transrectal ultrasound, but just to measure diameters. So just tell us a little bit more, just that so that our listeners can understand how difficult it is, and if it's worth it to learn, or what's your opinion actually?
So microultrasound is basically it's a high resolution ultrasound. So it's a higher frequency, so 29 megahertz compared to 12 megahertz for a regular transrectal ultrasound. But it's more like a linear probe that you know from testicular ultrasound. So the piazzos are on a line, so it's like a straightforward probe. It's not curved. So it's a bit different in that sense. So you only have one plane, and so it's a sagittal plane, and you scan the prostate going from left to right. So it's more of a rotation than like a forward-backward movement that you would do in a regular truss probe. Otherwise, it's quite similar to a regular truss. And when I started introducing it in 2018, of course, the residents in my program, they were also like the ones who were on the program, they had to learn the technology. We already knew, fusion biopsy, we were already doing a lot of transrectal ultrasound and looking at the anatomy. And I think it took about 50 cases to get your eye adjusted to the images. And of course, you have to go through a learning process, which is helped by the company. So they do have a learning platform, and you have to go through the cases. You have questionnaires in the end. So you go from level 1 to level 3. And of course, that goes along with the procedures as well. So it goes like 50 procedures, you're already doing really well. And at 100 procedures, you become an expert. So the same was true for the trial. Some sites have been using microultrasound for a long time, like Milan, like the Luger group. They were early on, like 2018, just like us. So we had a lot of prior experience, but other groups started, 50 cases was the minimum to get involved in the trial. So there were also parts of the groups involved that were starting off as well. And still the result was what I talked to you before. So getting back to your question, how long does it take? So of course, in my practice, and I do a lot of ultrasound, it takes about 2 minutes, 3 minutes. I would say maybe in the beginning, it's going to take maybe 5 minutes, maybe 10 minutes. But if you do a systematic scan of the prostate and you do it slowly, you can store the images. So the actual scanning time won't take so long, and you can go back and analyze the images later without the patient being there. So as long as your image quality is good and you maybe have someone to help you from outside, so you could show me the scan you did and I can give you feedback on it. So even if it's done in a standardized fashion, and that's something you have to learn, which will take, I guess, for about 50 cases, I would think it's probably a good thing to get the images image quality good, the gain the right way, and get the full prostate on the image. And this way you can even go back and look at the images later on and analyze them. So actually the scanning time I would say is maybe 1 minute longer or 2 minutes longer than a regular ultrasound, because of course you have to go through all the anatomical changes rather than just measuring the volume.
Well, it sounds easy to me, so it's good. That sounds great. And do you think that there will be some kind of softwares in the future, just like for MRI, that will find the lesions automatically, or do you think that it's too early to think about that?
Well, based on, of course, the data that was derived for the trial, there's been training platforms going on, and I know that there's going to be some test versions coming out not too long away from now, maybe early next year or something. So I know the company is working on it, but I haven't tried it myself. And I think, of course, the data is derived from the experts in the trial. So I don't know if it's going to be better than the expert. in the beginning, but it's surely going to help you train your eye. Because as any new imaging technology, when you go back, you remember your first days in residency, when you look at an X-ray or a normal MRI of the abdomen, you saw nothing, right? And you have to train your eye, or prostate MRI. I mean, we do all the prostate MRI courses, and I'm not just the ultrasound guy, I'm an MRI guy too. It's not one or the other. So you have to learn to analyze a prostatic MRI just the same way as you have to learn to do a micro-ultrasound. So you have to learn from your experiences, learn from your biopsies, go back to the cases, revisit the cases. Did you miss something you didn't see? Or did you see no cancer and all the biopsies were negative? So every case you do, you will learn something from it as long as you go back and revisit each of the cases that you've done. So it's like a step-by-step program as well.
And do you think there are any barriers to implement such technology?
Well, of course, I mean, in Germany, I think they have 25 machines, mostly in hospitals. So I think I'm in an ambulatory practice. So I think we're the only ones in Germany have it outside the hospital. Maybe probably the only ones in Europe that are that way. So we're but of course, I'm the early adopter. So the price, of course, for a normal practice is quite high. But of course, it's going to be cheaper than getting an MRI. I don't think it's going to be a product that's going to be for everyone, because you have to really focus on it and look at their data, be somewhat rigid about the progress. So you really have to make sure you do your due diligence, look at your data, see how you're performing. But once you do that, you're going to pick it up really fast. In the end, you have to do it, just use it like a truss. So not just scan the patient who comes for cancer, just scan the patient who comes for BPH, scan the patient who you already know has cancer before they go for, radical prostatectomy. So if you scan all these cases, I think you can go through your learning curve faster, because I'm not speaking of 50 biopsies, I'm thinking of just like 50 prostates. And if you think about 50 prostates or 100 prostates, you can do that in like 1 month, right? Or even faster.
An outpatient clinic, it takes like a week. It's not
Well, that's what I mean. So
right.
Actually, if you use it, and if, of course, you don't have to expect that you find everything from the get-go, but if you just use it like a truss and you do volumetry that you do anyway, and then look for everything else, then you're going to learn rather fast. So I think using it as such is going to make you faster. But going back to the price, of course, I think in the end it's going to be in a center of some sort, like an imaging center, maybe a hospital or a clinic, who's really dedicated to imaging.
Probably it's gonna be probably cost effective for some patients. Probably we won't solve all the problems we have for MRI, but maybe for patients that have a very clear tumor, probably it might lower a little bit.
I mean,
lists that we have now for an MRI. I mean, it's complicated to get it for everyone. I mean, it's
I mean, going back to the data. I mean, the data of the trial speaks for itself. I mean, we detected the same amount of cancer that we detected in the MRI. And these were all, centralized MRIs. The rate of PIRAS-3 was really low. It's, I think, 15%. So that really speaks for the high quality of the MRI images. Mm-hmm. And I think I recruited 90 patients. We only had, of which 85 were biopsied in the end, which was we were the third largest center to contribute. So in the end, I only had one case where the MRI guy didn't see the lesion, even going back, revisiting. It was a grade group 2 that was just not visible. All the other people we biopsied who were PIRAS 1 and 2 on my side were negative. So the MRI quality was really good. The guy who did the fusion biopsies was Carsten Günzer. He does 1,000 biopsies a year. He's on some of the papers with Barco on transperineal biopsies. So we had some really good guys doing the control arm as well. So we really made sure that the due diligence for the control arm was going to be high, because we knew as the authors that if we didn't make sure the MRI was going to be good in the trial, the criticism would be too big. And actually, overall, the detection for significant cancer is, at the top of our notch of what you expect, which is a positive selection, of course, if you have a good imaging. So, in the end, my opinion for micro-ultrasound is you can use it alone if you have no MRI. I think that's something we can take off the trial. Of course, once you've done your training on the machine. I personally don't see it as an against. It's not a one or the other, but it enables me to do a smart choice for the patient. If I clearly see a lesion, I don't need an MRI. I can just go for the biopsy, right?
Yep.
If I see no lesion, I can, in the early phases, I would say, if you see no lesion, add the MRI. If it also sees no lesion, then you learn from it. The more I think the harder part is going to be the negative predictive value. So really being sure you see nothing. That probably is going to take more than the 100 cases I talked about before. That's about finding cancer. Ruling out cancer, I would say, is probably going to take more, about 1,000, maybe 1,000 scans. To be really sure that when you do a scan of a PSA of 5 and you really want to be sure there's nothing there, you need a lot more experience. That's going to be the harder part.
Okay, and what do you think actually are the gaps in the actual literature? Meaning that do you think that there is the need of a different trial or a similar trial to confirm your findings? Or what do you think that researchers that actually have the machine should focus on? What do you think that the next steps are?
So, of course, the next two steps are already starting. Is Adam Kinnaird, the first author of the trial. He has two more trials set up. One is called Music AS, which is a micro-ultrasound with active surveillance patients. So before repeated biopsy, to see how we can use micro-ultrasound for the repeat biopsy setting before deciding against or pro biopsy versus MRI. The other trial is going to be the Music trial, which is basically somewhat like the OPTIMUM trial, but the patients with negative imaging results won't be biopsied. And so a negative micro-ultrasound and a negative MRI won't be biopsies, which is just the next logical step, just to make sure the data is there. This is something that has to be done, but for me, it's already said. But of course, I've been using technology for a long time. So for me, the interesting part is screening. How far, but that screening is different than cancer detection. So for screening, we're going to need a really, really high negative predictive value. And the trials still had 20% cancer on Primus 2. And so the question is, how much was that influenced by the groups that were starting off, and how much was it influenced, or how would it have changed for the more experienced groups? And we're going to do some subgroup analysis for that. And I'm going to be leading one of the new papers coming off the trial, because we have a lot of data that we didn't publish. So there's going to be, out of Optimum, a lot of questions that we can answer regarding some subset of data that we didn't put in the final paper. So screening is going to be a big question, because MRI and screening is quite costly, not available for every country, not in every part of the country. So maybe ultrasound can fill that gap to improve screening, but that's of course maybe in the future. I can't tell you about it yet.
Well, it sounds like I think everybody was waiting for this trial to have actually to buy the machine, because I think that this gives you, at least it gives you a little bit more certainty in using it. I mean, that you might. Because in the first trial, there were some people, I think that you agree with me, were skeptical about it.
Absolutely.
Probably, but I really believe that probably as you said, probably in a normal practice, it might be difficult to buy the machine alone, but in a hospital, it can really reduce the workload for radiologists, Another thing that probably will be interesting is to see from the trial that you talked about, on the Music trial, probably is to see the follow-up of those patients with negative imaging, because, like for MRI, very often they say that if you don't see it, it's not important. So that's one thing that we might learn from this trial. So I think that it is an important trial, I think.
Absolutely. And the follow-up is planned, I think, for 1 year at least. But of course, as you know, follow-up trials are hard. There's one follow-up trial that was prospective on MRI that I was also part of, which we published. It's called the ProCom trial. It was published in JAMA Oncology last year, which is the only prospective trial with 3-year, not just follow-up, but monitoring of the patients. And it's the only one because it's hard to do. To keep everybody on track, to keep the patients on track. That's why there's never been any data precision. I know Viru, they planned to do a follow-up on the negative MRI group that didn't get a biopsy, but we're never going to see that data. It hasn't come out yet. So for microultrasound, we have to do the same, but we have to be fair enough to know that we don't have that data for the MRI as well. So we're just believing on the negative predictive value, right? And which I believe in. I'm a believer. Don't get me wrong. But we have to be fair. If we don't have that data for microultrasound, don't kill it because we only just have it for the MRI as of last year in December.
No, it's as you said, we're believers. That's right. Because I believe too that negative MRI it's okay, but
absolutely okay.
The data is not there. It's just I don't know. I think for all urologists will probably agree on this that when you see a negative MRI, you're a little bit. I mean, you're more confident to avoid the biopsy with the patient. I mean,
absolutely. Especially, of course, if the MRI is done in a center. So you really have to make sure the MRI quality is good. And I think that's going to be the main focus on microultrasound as well. If we take this technology and just put it in there without checking on it, it won't receive the same. So we have to make sure we have of excellence for microultrasound just as we have for the MRI as well. So I think once we get that on a broader scale, there's quite a large potential for microultrasound because it's very fast. And you can counsel the patient on the spot on what to do. And it's not that the patient's going to get lost. I mean, you can tell them to come back if you're unsure. They come back in 6 months. And you monitor them again. You can add the MRI to the pathway as well to make sure. So I'll mostly add the MRI for the cases where I'm unsure. There's Primus 3, which is the same as Pyrex 3. It's not so easy to manage. So you see some changes. You have maybe a low elevation of PSA, 4.5, in a 6-year-old man. You see something that's it's not cancer, but it's nothing bad. So you can already tell the patient, well, there's something there, but it's not bad cancer. This I can tell you. Let's add the MRI to it. If it's Pyrex 2, you don't do anything. If it's Pyrex 3, you monitor them more closely. And if you miss something, which is going to happen in 10% of cases, then you do the biopsy nonetheless. So I think, but still the patient will feel that you had a smart choice on how you're going to go about it. And that's what I like in my daily routine. But we do a lot of scans. I mean, I probably do, 10, 20 scans a day. So we're already seeing, second opinions, negative MRIs and so on being sent to us for like a second opinion. So I think the other urologists, at least in Berlin, are taking on the notion that microultrasound can add something.
I really think that it's new technology. I think that it's actually non-invasive, meaning that, as you said, you can manage patients straightforward without waiting or anything. So I really think that this will probably help a lot the urologists if we keep, as you said, high quality. So I'll leave you for the final thoughts for our audience. So please just tell us your final thoughts on the topic, and so we can close this very interesting podcast.
So thank you, Ricardo. So I think really read the paper, look at the data, be critical about it. It's fine, but I think embrace this new technology. Give it a good chance. I think it's really a huge step forward. Not to replace the MRI, but to add to the MRI in combination. So we're still going to need both imaging modalities. It's not going to save you from having just one or the other, but I think it just enables us as urologists to really counsel the patient directly and reduce the stress for the patient as well. Because in the end, of course, as clinicians, we're looking for cancer, but in the final end, the patient wants us to tell him that he's healthy. So if we have something, a tool that can on the spot tell the patient that he's fine, which is going to happen in more than half the cases, the That's a huge benefit.
Okay, so thank you very much, Anis. I think that we've gone through micro-ultrasound deep. I think that the ones that will hear us will have a clear image of what are the actual benefits of micro-ultrasound. So I thank you, and I thank also all your group for publishing this very interesting trial. And I hope you will consider for sub-analysis our journal. I think that is just the right place to continue talking about biopsies. It's one of the main topics of our journal. So I thank everyone for hearing our podcast on YouTube or Spotify. And I thank everyone and say bye-bye. Okay, thank you, everyone.